I'd like to introduce Dr. Neeta Pandit-Tasker from our nuclear medicine group, who has been doing a lot of interesting work in using novel technologies to try to image the immune system of patients undergoing immunotherapy treatment, and we'll hear a little bit about where the frontier is in that respect. Thank you, Neeta.
Thank you, Mike, and organizers for inviting me to give this talk. So the topic is PET scans and experimental nuclear medicine imaging to inform us about the checkpoint inhibitors. Here are my disclosures. So probably everyone's familiar with FDG PET, which is the only clinically approved PET tracer that is integrated well into the clinical management of a lot of malignancies. As we all know, FDG PET essentially is a metabolic tracer that's based, or the mechanism is based upon the uptake of glucose, which is increased in the cancers. So, but we know that this is still a non-specific process, and number of inflammatory conditions can also show increased uptake. In that, I showed a case of sarcoidosis, and also inflammatory lymph nodes infections. They also show increased uptake with FDG PET. Specifically, as the checkpoint inhibitors is concerned, there are side effects which are related to inflammation, and these can be detected with, this will also light up with FDG PET. That could actually be confusing and can be problematic when we want to assess the response. So a lot of false positive can occur and have been assessed, and especially pseudoprogression that Tara just mentioned. So criteria has been looked into as to how we can assess pseudoprogression or versus a true response to treatment. So a number of issues still pertain to how best we can use FDG PET imaging in management paradigm for patients who are getting checkpoint inhibitors. So in terms of the response criteria, a number of response criteria have been used in with FDG PET in solid tumors, but it's been found that those do not directly, or they're not optimal for assessing patients who are getting checkpoint inhibitors. So some of the studies have looked into other criteria and integration of multiple other parameters. So I'll just briefly refer to that. And then there's data emerging for predictive and prognostic value for FDG PET. So just to show you an example, in this case, this is a baseline study in a patient with lung nodule showing uptake. The patient was treated with nivolumab, and 2 cycles after FDG PET scan was repeated, and you can see that the lesion is still bright on FDG PET. Probably it's slightly increased in uptake, but you also see 2 other lesions within the lung and the mediastinum that could be misinterpreted as progression of disease. And in this case, by repeating imaging at later time point, after patient got 6 cycles of treatment, you see that the disease is pretty much resolved. So this is a typical example where you can actually see increase in uptake or within the lesion as well as number of lesions, and it has been recognized that this could all be just pseudoprogression. So in terms of the early time point, but in the previous case, but in this case, again, a baseline study and a follow-up imaging at 3 months post-treatment, you can see again you're seeing number of lymph nodes that are showing increased uptake. And again, in this case, a follow-up imaging showed resolution. So the process of the inflammatory response that can occur with checkpoint inhibitors can cause increase in uptake within the lesions and also uptake in the lymph nodes, which may just be reactive. So a number of unanswered questions remain, although many studies are looking into this, and some of the parameters are out there that are suggesting that we can assess or overcome these issues. So as far as visualization of new sites is concerned, the question is it progression or immune stimulation? And how can we identify pseudoprogression? And then, as you can see that at an early time point in 2 weeks versus 3 months time point imaging after a number of cycles, what is the duration that you can still encounter these changes in the signals on FDG PET? And in that context, what would be the optimal time point for response assessment? And obviously, we want to know it as early as we can so that we can either change the management or continue to give the same treatment if it's effective. In terms of prognostic and predictive value, is there an SUV cutoff that we can identify? And how about number of lesions that may be predictive? And in that regard, what about the size of lesions? And whether nodal versus other sites that we see would have an impact on prognosis. So also we don't know whether the signal of FDG PET really correlates with the expression of PD-L1 or PD-1. There is data that suggests that yes, it does, but clearly there is, as of yet, no SUV cutoff that can be universally applied to all the tumor types that get treated with immune agents. So as far as FDG PET is concerned, most of the data is in melanoma patients. Much of the data is retrospective, and the prospective studies that are out there are small in numbers, and there is a lot of variability in methodology. So where are we? I'm just going to summarize a few key findings from the studies. So it's known, and also more so from the data from melanoma patients, that FDG PET may reflect both viable tumor as well as inflammatory reactions and adverse events that can happen with treatment. And there is increase in visualization of tumor lesions that may cause pseudoprogression. So in context to that, a study was conducted where they looked at the absolute number of new lesions and whether the number of lesions can help us predict the responses. And what they found was a cutoff of 4 new lesions, irrespective of their size, will have poor prognosis or will be an indicator of non-response to treatment. And also, if there are 3 new lesions that are 1 centimeter or larger in diameter, or 2 lesions with 1.5 centimeter in diameter, will also be reliable indication of treatment failure. So the increase in number of new lesions, even after early onset of treatment, after 2 cycles, seem to correlate with therapeutic outcomes. So if you see an increase in number of lesions, if there are a certain number and size, that can indicate poor prognosis. Based on that, this criteria, which is metabolic, the PET metabolic response criteria, has been generated, and using that in this study, they were able to segregate out patients who would have clinical benefit versus those who would not, with a sensitivity of 93.6% and specificity of 70%. And what about if we have not just increase in numbers or not increase in number of tumor sites that we see, but increase in the size of the lesions? And again, it's been, in this example, you can see that a number of sites are lighting up in the mediastinum and in the retroperitoneum and in the bones. And clearly that the size or there is increase in the extent of uptake within the lesions that were already seen. And again, a further follow-up does show that these sites are regressing in their uptake of FDG PET. So we know that it's not just the number of lesions, but also the size of the lesions may increase, as Dara already pointed out. So looking at that, Cho and colleagues actually said that, or observed that using RESIST as well as PERSIST criteria can actually help better delineate these changes. So a combination of changes in lesion diameter can have more accurate prediction of eventual response. They also identified that SUV threshold of 15.5% change from the baseline, beyond which it will signify poor prognosis. And again, in limited data in bladder cancer, SUV cutoff of 22.7 was actually thought to correlate with PD-1 and PD-L1 expression. So for monitoring, how often do we want to get the PET imaging done, because we know there's pseudoprogression, interim PET after 2 cycles can lead to that finding, but it was found to have high predictive value for response in post-therapy scan in about 82% patients. By post-therapy, of course, it means that after 4 cycles of EP. And a late follow-up study example after 4 cycles is recommended to exclude pseudoprogression. But overall, like I mentioned, larger studies are needed to validate the role and how exactly we are going to use across all the tumor types. So given the certain limitations that we just discussed with FTG PET, there is interest in actually developing specific imaging agents that can actually look at the process itself. So lately we have actually worked with an antibody that targets CD8 with the idea that you would be able to look at the CD8 presenting T cells, which would be upregulated or modulated after the checkpoint inhibition. Similarly, people have radio-labeled the drugs itself, and this is increasingly being used for drug development. So we have zirconium mona, durva, and pembro and nivo that have been labeled with zirconium-89, which is a PET tracer isotope that enables us to track where exactly these drugs are going and targeting the tumor tissue. So just to briefly go over some of our experience, this is a zirconium-labeled IAB22, which is a mini body. It has a smaller size of 80 kilodaltons. It is labeled with zirconium-89 that allows us to track where exactly the mini body is going and targeting. And because this is an antibody against CD8, we would expect that it's going to show us the presence of T cells. In a pilot study, we evaluated, in a multicenter study, of course, 15 patients with melanomas, lung cancer, or hepatocellular carcinoma. 2 patients were treatment naive, and 3 were on checkpoint inhibitors. And there were 10 that were actually on checkpoint inhibitors at various times between 2 weeks to 2 years. So just to show you some examples, this is a patient with metastatic melanoma, and the patient was previously on EP and was most recently changed to pembro. And you can see that FTG PET shows lesion in the muscle in the shoulder, and you can see that the tracer is accumulating in sites that are normally known to have T cells. So T cell rich tissues, spleen, and bone marrow are lighting up, and early on you can see there is tracer within the lymph nodes, again saying that it's going and settling down in areas which are T cell rich. And in this case, the patient did get a biopsy in the lesion, and you can see that there is T cell infiltration in this patient, in the lesion itself. A patient with hepatocellular carcinoma who had initiated treatment 2 weeks prior to our imaging. Again, you can see intense activity within the spleen, bone marrow, and here are 2 lesions within the liver, which are showing accumulation of the tracer, and you can see intense activity. This patient actually had very good response to treatment. In contrast, you have a situation where you have not initiated the checkpoint inhibitor treatment. In this case, FTG PET is showing intense activity within the lesions. So we know that there are lesions, and these are not picking up the tracer, which means that probably there is immune modulation, of course, is not yet happened because the patient's not been on treatment. So this we would consider as a negative case, and we hope that if we start the treatment, this is going to show us increase in the signal. Similarly, it can actually also tell us about the heterogeneity of signal or T cell infiltration in various tumors within a patient itself. So in this case, you can see that the lung cancer or the lesion in the lung is not showing uptake of the tracer, but there are lesions in the bones that are showing intense uptake of the tracer. So using this, we hope that we can delineate what the changes would be following the checkpoint inhibition, and probably will have a more prognostic information as against just using non-specific tracers. So given the encouraging results from phase 1, a phase 2 study is already been initiated in other centers, and we hope to start the study here. But in this, more patients are going to be studied, and there will be a correlation of biopsy and other markers that would enable us to prove on a tissue basis the T-cell infiltration and correlation with the uptake of the tracer. So like I mentioned, we have the ability to actually radio-label the drugs themselves to be able to show targeting and presence of the target for treatment. European group actually used zirconium atezolizumab to target in patients. And multiple time point imaging was done as a phase 1, and 22 patients were studied. These included bladder cancer, lung cancer, and triple-negative breast carcinoma. And again, you can see that there is distribution within the various tissues. What was important in this study was they did have biopsy correlation, IHC correlation in the lesions. And you can see that there is heterogeneity of uptake within a number of lesions. So there are larger lesions here in the nodes and the abdominal wall that is showing intense activity. However, within the lesion itself, there is heterogeneous distribution of the tracer. And also there are other lesions which actually do not pick up the tracer. When further analysis was done between different tumor types, it was found that the triple-negative breast cancer actually showed lower signal. And also there was differences in uptake within the metastatic sites, or where these metastatic lesions was. So for example, bone showed lower uptake as against some of the other soft tissue and liver activity. So overall, I think a single agent is able to show the heterogeneity of the target itself, in this case PD-L1, in patients, thereby giving us a bit more insight into what could be the differences in responses and why there is a heterogeneity in response within a patient itself between different two lesions. So they also looked at the progression-free survival and overall survival, and here you can see that this was better related to the signal or the SUV of the PET tracer as against the IHC. And also the RECIST responses were better correlated with the SUV max in the patient. So the higher the uptake, probably the higher expression of the target itself, and hence better responses. By different labeling techniques, we can also look at two parallel processes at the same time. In this case, zirconium nivolumab and a ligand, which was labeled with F18, a shorter isotope, was performed, and this is a PD-L1. This is a target against PD-L1, and this is PD-1. So you're able to look at both targets at the same time in a single imaging modality. So you can see that in this patient, again, the distribution, and you can see targeting of lesions. And they again found that the uptake values were different between non-responding patients and responding patients. There was a trend towards significant value of difference in the uptake between responders versus non-responders. And just to say that increasingly these kinds of approaches are being used for drug development, and in this case we have the BMS compound that we are using to evaluate patient, in this case brain lesion prior to treatment, and you can see that there is uptake. So one would think that there would be a response to treatment in these patients. Again, this is a zirconium-labeled anti-LAG3, and LAG3 is, again, a component of tumor microenvironment that can affect IO therapy, and we are looking to start a phase 1 study to evaluate its usefulness as a tracer to prognosticate responses and drug development. And this is just a list of number of trials that are in phase 1 or phase 2/3 stage. which actually is utilizing radio-labeled antibody targets itself for looking at responses. So to summarize, FTG PET is available and is used clinically for evaluating these patients, but there are certain limitations, and there is emerging data for predictive and prognostic value. However, the criteria for assessment needs to be validated, and we need to come up with set guidelines that would be applicable to all tumor types. Novel PET tracers for imaging targets can offer more specific information and can allow for evaluating target expression, evaluating dynamic changes with IO therapy, prediction of response, and prognostications. But of course, more studies are needed. So thank you.
Thank you, Neeta. That was an excellent overview of where we are with this field. Any quick burning questions? And then I know, real quick, Ann? Yeah.
Just quickly, I thought it was fascinating, especially the PET studies targeting CD8 positive T cells. I would just encourage you in your studies to think about also mechanisms behind adverse events. We're often faced with the question, what is the mechanism behind an immune-related adverse event? Is it T cell mediated, is it cytokine mediated, or antibody mediated? And this might be a way to non-invasively answer that question.
Right. I think this was discussed when the phase 2 study was being planned, and I think while we are first focusing on the tumor types, but yes, it's possible that the adverse events are also happening because of the modulation, and we may be seeing some uptake because of that. That's a good point.
Great. Well, thank you very much, Neeta. I appreciate it.